Hi, welcome to another episode of MYD Global. I'm your host, Leanne Hackman-Carty. In this episode, I'm speaking with Dr. Ciatone. He's an expert when it comes to disaster medicine. And just to be clear, disaster medicine isn't exactly like emergency medicine. So stay tuned as I talk to Dr. Ciatone about the difference and what he's doing in the area to make a huge global impact. Hi, how are you?
I'm good. How are you?
I'm good, good. So before we get started on the topic today, just curious if you can tell the viewers a little bit about yourself.
I'm an emergency physician by training here in Boston, and I'm on staff at Beth Israel Deaconess Medical Center, and I'm also an associate professor of emergency medicine at Harvard Medical School. But early on in my career, I became interested in and involved in disasters and disaster medicine, and did a lot of work in that arena. So that's really my area of expertise now. Some 25 years later, I have had the opportunity to be a commander of a federal disaster team. Early on, did a lot of international work in disaster response, preparedness, and response, and then put some of that experience together into a textbook that's called Ciatone's Disaster Medicine. It's now going into its third edition, so I've had a chance to really kind of explore this area of disaster medicine, try to help define it as a field. I'm also currently the president of the World Association for Disaster and Emergency Medicine.
Wow, that's fantastic. So tell me a little bit about that whole field of disaster emergency medicine. What components or what exactly is involved?
Well, if you have a couple of days, I can tell you all about it. But first of all, disaster medicine is a little bit different from emergency medicine. Emergency medicine, ER doctors, we go to work, every day in our shifts and go to the emergency department and see patients. There is no disaster clinic, so disaster medicine specialists don't wake up in the morning and go to disaster clinic and see disaster patients, right? We're always working around this area where there are these low frequency, high acuity events. But because of that, there really needs to be an awful lot of thought put into mitigation, preparedness, and response. So disaster medicine is the healthcare aspect of disasters, dealing with disasters essentially. And we work on what's called the disaster cycle. So again, it's sort of a circular way that we proceed in mitigation, preparedness, response, and recovery. And in disaster medicine, we do specific things in each one of those areas. And disaster medicine, as we define it, and as I've done in my textbook, really encompasses a lot of things. So it can be everything from what I like to call the lights and sirens disasters, like mass casualty incidents, bad accidents, explosions, bombings, terrorist attacks, to other longer term events like we're living through now, right, with the COVID-19 pandemic, which is also a disaster. But as you can see, just by comparing those two basic areas, you can understand that disaster medicine involves different things depending on what it is that you're preparing for and responding to. So natural disasters, particularly in developing countries, require a certain, skill sets essentially to be able to practice in those sort of austere environments and to be able to respond to such events. The mass casualty incidents or lights and sirens disasters, I like to say, really depend on a robust emergency system. So that really does get more rooted into emergency medicine. Whereas the pandemics and some of these other longer term disasters, humanitarian crises, pandemics, that really is more based on a public health response. It's not so much that lights and sirens response, I like to say. So that really depends on a robust public health system. All that, sort of falls under the umbrella of disaster medicine. But as you can see, they're relatively, different things, and how you must, again, mitigate, prepare, and respond for them.
So I'm just curious, as far as to get training in this field, is there a special, like the work you do in Boston, is that doctors and nurses and various healthcare professionals that are taking this specialized training, or how do they get this expertise?
Yeah, so there is specialized training, and I actually run the largest disaster medicine fellowship program in the United States. We have anywhere from 10 to 12 fellows every year, and they come from around the world. So there are fellowship programs like that. Again, it's a year-long program. So we have doctors in that. We also have a disaster nursing program fellowship that we train nurses as well. Now, there's a number of other training programs, shorter term training programs in different aspects of disaster medicine. There's shorter programs in, let's say, chemical, biologic, and radiation. There's other shorter programs in things like the incident command system, et cetera. So there's a number of areas where you can explore and get training. But as far as the more formal training, yes, there are in Europe, there's a master's program or a couple master's programs in disaster medicine. Here in the United States, we tend more to do fellowships. So there are fellowships in disaster medicine. So yes, there is the ability to do formal training.
And so when you look around the globe at this area, where do you see this whole field going in the future?
Well, I think what we're living through now really is demonstrating the need for a field like disaster medicine. And we can look at again, different kinds of disasters and how we go about preparing and responding to them. Looking at this pandemic now, I think the lessons learned coming on the other side of the pandemic will be numerous. We seem to go through these pandemics time and time again. There's been 8 or 9 over the last 100 years, some much larger than others, but and in reality, we go through a seasonal, a pandemic every year with a seasonal flu, but certainly on a much lower scale. But there are things that we learned from that what we've seen from that we don't really seem to learn so well sometimes. Less things such as early containment. When we see a new illness seeming to arise, when we see what might be a novel virus arising, how we really have to jump on that very, very quickly, very early, and contain it, just keep it as just a local outbreak so it doesn't progress to an epidemic and pandemic. And some of the other aspects of this response that we could have done better, like sourcing PPE better, that whole idea of supply chain and stockpiling and the way that we do crisis standards of care. We learn different ways of doing that all the time. So there's that. There's also other things that are happening, that we're going through just now, almost ending the most active hurricane season in the Caribbean, I think, that we've been through in history, I think, if not very close. So, disasters don't stop just because there's a pandemic. So you also have that interesting sort of dynamic between dealing with the pandemic and then dealing with other large disasters, natural disasters and others at the same time. So, for instance, we use sheltering as a significant piece or part of the response to hurricanes, for instance, and sheltering in the COVID age is a whole different ballgame, right? So there's a lot of complexities, and I think that data has proven this out, that if you look over the past 100 years, let's say, there are more and more disasters affecting more and more of us. And there's a number of reasons for that. We're growing in population. We're moving our populations closer to areas that are more disaster prone. We have much more of a presence on coastlines now than we did 100 years ago, let's say. We have a tremendous amount of technology, and we're technology driven, which also means that we are susceptible to technological disasters. So there's a lot of different, and climate change, of course. There's a lot of different factors, I think, that are coming together to really increase not only the numbers of disasters that we're experiencing, but their impact on us. And then also, of course, we have to worry about intentional events like terrorist attacks. And as part of the program that I run, we did come up with a term called counterterrorism medicine over the last 4 or 5 years that we've been researching and publishing on and discussing and trying to define that as a really succinct and different subset of disaster medicine that demands, I think, a somewhat different skill set and knowledge base.
Well, I commend you on the work you've been doing, because many times we don't get the pleasure of being at the forefront of an industry or of a profession, and so to be able to write books on this and to develop training programs and train people around the world in this area, I think is needed more today than ever before. I guess just from a personal perspective, what is the thing that is most rewarding to you in this field?
Well, everything in healthcare, everything in medicine is rewarding. It's rewarding, to go to the emergency department and treat patients, and that sort of individual doctor-patient interaction relationship and have positive outcomes from that. That's all very rewarding. But what's rewarding about this now too, the public health piece of it and the education piece of it is I can now go and for instance, from our fellowship program, we've been going now, it's almost 15 years. We have 67 to 68 alumni and a current class of fellows. So we have a lot of practicing disaster medicine specialists now that we've trained that are around the world. And really, you'd be hard pressed to, see a large scale disaster anywhere in the world and not have one of our alumni involved, in a leadership capacity in responding to it. So that's very rewarding as well, knowing that you sort of. This is true in any field, but particularly in disaster medicine because they're so unique and so different. The experience that you're able to glean from just the field work that you've done, and I've done a lot of field work early in my career, you can then kind of give to others and teach others from your personal experience and then have them go off and do some of these great things too. So it's very rewarding in that sense.
That's great. Well, before we wrap up, is there anything else you wanted to mention that perhaps I didn't ask about?
No, I think in general, if you were to convey one important thing to, the audience that you have, it would be that, particularly in this pandemic, for instance, there are times when the community needs to be involved. We're in this pandemic now in this period where we don't have the vaccine yet, and we don't really have good therapeutics yet. So we do this thing called non-pharmaceutical interventions, and that's what we've been living the last 9 months, 10 months. And that's essentially the social distancing, personal hygiene, wearing masks, the lockdown when the disease prevalence gets really high. And people really need to buy into that because what these, we call them NPIs, non-pharmaceutical interventions, what these things do is that they bridge us from the onset of the pandemic to the point when we do have a vaccine and we do have good therapeutics, because it's at that point that we are going to achieve the herd immunity you're hearing about, but it's going to be vaccine-mediated herd immunity, not the other way, which wouldn't be so good. We're going to achieve that, and we're going to get on the other side of this pandemic, and the pandemic's going to go away. The virus won't go away. In fact, we'll probably have, along with our flu virus, we'll probably have a coronavirus vaccine every year as well. But it's really the community buying into it and taking action that's going to bridge us to the resolution of this pandemic. So, that's really, I think, the one thing to convey to your audience, and that is participate in the ways that you can, wearing masks, social distancing, and just understanding how to keep this virus from, going from one person to the other. The virus can't live on its own, right? It can't walk down the street and knock on your door and infect you. It's got to be, transmitted. If this was a utopian world, and you could take every single human being and put them in a box away from every other human being for the next 2 weeks, this virus would disappear. But obviously we can't do that. So all of these non-pharmaceutical interventions are our best attempt to try to approximate that, just to not allow the virus to transmit.
Yeah. Well, thank you very much for taking the time today. I appreciate all the work you do. And I'm glad to bring and highlight some of that work so others can find out about it. So thanks again.
Great. Yep. It's been my pleasure.